Once the drapes are applied and the incision is identified, a linear incision is made. It's important to identify Camper's fascia. Once this is elevated, you'll be able to identify the medial border of the patella. An incision is made through this retinacular tissue, which is allowing exposure of the joint, and it's important to allow a small cup of tissue along the edge of the VMO so that it can be reattached. Try to make your incision through the capsular tissue in a fashion that is flowing and not with sharp angles. Visualization of the joint allows for dissection along the medial aspect of the knee. With the medial dissection, one can begin the soft tissue release for a varus knee. Following this, a portion of the fat pad is excised to allow for mobilization of the patella. The proximal and distal extent of the incision is clearly dependent on the soft tissue tension. The eversion of the patella is facilitated by utilizing the talc lift. It's important when exposing the knee that the lateral aspect of the knee is exposed, and I resect the anterior 1/3 of the lateral meniscus. The Blundholmen or Darrell retractors are placed in the gutters superior to the meniscus, and once they are in position, it allows adequate exposure of the knee joint and initiation of preparation for the drill hole within the femur. Remove this anterior 1/3 of the lateral meniscus, and this will facilitate the seating of the jigs. The drill hole is made in line with the femur. It's important that you use your fingers to act as goalposts for the insertion. Over-drill this area as well. The insertion of the intermedullary sword allows then for the distal cut, typically 9 millimeters with the Zimmer system, is removed from the distal femur. Be cognizant of the amount of bone that is removed when you make your distal cut. It should be what you would template from your preoperative template. Once the distal cut is set, the oscillating saw is used to remove the distal bone. Utilize the wing to allow for an assessment of the amount of bone that is going to be removed prior to the resection. It's important that the next step in sizing is done based off your preoperative templating, as well as what appears to be an appropriate size. The placement of the anterior, posterior, and chamfer cut jig, in this particular case with the next gen high flex, gold block is used. Once this gold block is seated, utilize the 6.5 cancellous screws to secure the jig to the knee. Either an oscillating saw or a reciprocating saw can be used to make the cuts. Ensure with your bat wing that the anterior cut does not notch the femur, and if additional resection is necessary of the skin to expose the anterior portion of the femur, then do so. Once the chamfer cuts are made, an osteotome is removed. The posterior condylar cut pieces. The reciprocating saw is used to make appropriate cuts for the trochlear notch. Screws are then removed and appropriate drill holes are made for the pegs of the femoral trowel. Distal cut then is completed. An osteotome is used to remove the posterior condyles. The reciprocating saw is used to remove the anterior chamfer as well as the trochlear notch. It's important to utilize the blunt Homan retractors as protectors for the collateral ligaments when making the posterior condylar cut.
Noise.